Good afternoon. Good afternoon. All right. Well, I am sometimes called DC's AIDS czar, or czarina. And it's my mission, along with Mayor Fenty and a whole bunch of brilliant, passionate, committed people in this city, to try to change the future of HIV in the district. And so there's a couple of things I believe in. One, I believe in data, okay? I believe in data for driving sound, effective decision-making. I'm a data dweeb, actually, so I love data, too. But I believe in data. I also believe in minding the gap. And what I mean is the gap between what we know, what we already know, what we think we know, what we want to know, what we want to talk about, and what we observe in the data about what else we know, what we need to talk about. So that's what I'm going to talk about here today, because I really believe that gap in between, is where innovation and paradigm shift has to happen if we're really going to transform the future. So, data. Numbers. 1%. This is the threshold that CDC and the World Health Organization set in defining a severe HIV epidemic. If 1% of your overall population in your area is HIV positive, they say, wow, you might have a severe HIV epidemic. 3.2%. The proportion of DC adults and adolescents who are already diagnosed and living with HIV here and now. So 3 times that minimum threshold for a severe epidemic. 4 to 5%. The proportion of DC adults and adolescents that research would suggest are truly living with HIV, because that includes all the people who are already infected with HIV and don't know it yet because they haven't had a test and they haven't been diagnosed. So that's the situation we're talking about here in DC. And so I've been in this job about 3 years now, and of course, when I started back in 2007, everybody knew we had a bad HIV epidemic. This has been no secret for any amount of time. And so the first thing we did is say, okay, what do the data show? What are the concretes of what we know about the who, what, where, when is living with HIV in the district right now? And the data showed this. We had no data. We had no concrete data. We had a lot of faith, we had a lot of ideas, we had a lot of experience of what was going on, but we had no data. And I wasn't the first to discover this. So the team had been working on putting data together, getting caught up on what we should be doing as the government in terms of collecting and disseminating and really organizing data and information, such that right before World AIDS Day, so a few months later in 2007, we launched the first AIDS data for DC in 5 years, and the first HIV data in DC ever, because we hadn't ever counted and collected and analyzed that data ever before. So we were excited. We were like thrilled. And we found some really surprising things. We found that despite what people believed, HIV not only had high rates, we did confirm those high rates, but it affected really in extremely high epidemic rates, 7 out of the 8 wards of our city. We found that Black women, white men, Latino men, Black men, all had rates of HIV at 3% or higher. So we found some really surprising things, but we were excited because data is power, information is power. This can help us really hone in and prioritize of what we need to do next to change the future. And so, of course, we couldn't wait to share it. You know, launch the data, go out, take the show on the road, start telling people what we found, what the data showed, what we found. And for me, what was even more surprising than the data were people's responses to it when I started talking about it. And invariably, there became these themes that it didn't matter if I was talking to an HIV group, an advocacy group, a faith leaders group, community group, the community board for public radio. 4 things would always come up. And people, they might listen to what I said, but they might cut me off. And they say, Dr. Hader, you don't know what's going on. Let us help you because you're new here. Let me tell you what's going on. Say, HIV in DC is all about 4 things. And they'd roll off these 4 things every single time. Didn't matter what kind of group, all educated, committed, really, engaged folks. And so these became my 4 conventional wisdoms, because I could predict that whoever I was talking to, they were going to come up. So you couldn't ignore them. And you'll notice I'm saying they're conventional wisdoms. They're not myths, because everything I'm going to show you, they have truths. They either have a little bit of truth or they're all true, but they're not the complete story. They're true, but they're not the truth, the whole truth, and nothing but the truth. And so there's a gap. And the reason I have to talk to them when I present data and why I want to talk to you about them today is because even though they're truths and they have elements that are important to address, they are so pervasive and people are so overwhelmingly entranced by these conventional wisdoms that sometimes you can't talk about anything else. They almost become distractions to the rest of the conversation, to talking about these conventional wisdoms and then the rest of the complexities and the realities that we have to address to figure out what to do. So, are you ready for them? HIV in DC is all about, and which people mean is only about, HIV in DC is all about crazy, sexy young people. This actually came up in the green room, by the way, before I came out here. So, crazy, sexy young people. HIV in DC is all about men on the down low. HIV in DC is all about men coming back from prison and bringing HIV with them. HIV in DC is all about poverty. So again, you can see there are important things we have to address in these conventional wisdoms. But what I'm going to propose is they're not the whole story. So, one at a time. Crazy, sexy young people. What do we know? Well, we know of DC high school students, 40% are having sex, 20% had 4 or more sex partners in the last 12 months, and 14% had sex for the first time before they were 13 years old. So do we have crazy, sexy young people? Yeah, we do. Well, what else do we know? Well, we at the Department of Health, we actually have a program, it's a growing program, where we go to high schools once a year, and we go in and we do these series of sort of sexually transmitted disease, STD 101 talks, and then we give kids the opportunity to pee in a cup and get tested for chlamydia and gonorrhea. Now, we don't make anybody participate in this. It's all voluntary. Parents can opt their, high school kids out, et cetera. So don't go around saying that, Dr. Hader is forcing all DC high school students to pee in a cup. But a lot of them participate. So in 2009, we had 5,300, mostly DC high school students who did participate in this program. And what did we find? We found on that one day where we showed up and said pee in a cup, at each high school, between anywhere from 9 to 14% of those kids had an active, untreated, undiagnosed, oftentimes asymptomatic STD, usually chlamydia, that they wouldn't have known about and wouldn't have gotten treated unless we were there. What else do we know about? 0.1%. That's the proportion of 13 to 19-year-olds in the district who are HIV positive. So it doesn't look like that 9 to 14%, does it? And it doesn't look like that 3 to 5% that we talked about being HIV in DC. So why is that? One of the truths that we don't talk about a whole lot is that HIV is not just about having unprotected sex, for example, But it's also about you can have as much unprotected sex as you want. If the person you're having sex with doesn't have HIV, you're not going to get HIV no matter what. So most of the folks that kids are having sex with don't have HIV. So no matter how much risky behavior they have, they're going to get chlamydia if that's what their partners have, but they're not going to get an HIV if they're not having sex with anybody who has HIV. So what is HIV and DC all about then? So the harsh reality, 75% of new HIV diagnoses in the city are in people 30 years old and older. 90% of the people currently living with HIV/AIDS in the district are 30 years old and older. So what does this mean? This means that HIV is not a crazy, sexy young person's disease. And if we don't sort of start to grapple with that, we can miss the boat in two major ways. Number one is we might not get kids what they need, okay? So do these data suggest that young people don't need to know about HIV? No. If anything, to me, they suggest the opposite. They suggest that we need to build skills, awareness, sexuality comfort, and healthy relationship aspirations in our young people that are going to last them not just till they're 20 or 25, but until they're 35 and 45 and 55, because that's what we need to do to keep them safe from HIV. Second part that we can miss the boat if we don't pay attention to this is if we want to stop HIV in its tracks right now, if we want to stop ongoing transmission, it's got to be about grown-ups. So adults who want to talk a lot about what the kids need to do need to be talking to each other about what we all need to do. Not just about crazy, sexy young people. Men on the down low. So, men on the down low. Oh, I'll go back once. Gay, bisexual men who are in the closet, who have hidden their sexuality from their families and friends and the people in their relationships with, have been vilified as being the sole cause of all heterosexual HIV in the district, well, actually in a lot of the country. Which is sort of interesting considering if you look worldwide, the vast majority of people in the global universe who are living with HIV got it through heterosexual sex. But apparently in the United States, that's all due to men on the down low. So, and this is a very compelling, pervasive, hot topic. Oprah did a show about this in 2004, and the conversations have never stopped since, right? Because when Oprah does a show on it, it's not going to stop. So put that aside for a second and say, well, what do we know about the heterosexual HIV epidemic in DC right now? Do we know anything? And actually, we do. So we did a study that included 750 people, all of whom had had heterosexual sex, so sex with a member of the opposite sex in the last 12 months. Didn't have to be gay, straight, bi, on the down low, anything else. If you'd had sex with somebody else of the opposite sex, you're included. 5%. The rate of HIV in this sample, in these people. 5% were HIV positive. 50%. The proportion of those who were HIV positive who didn't know it until they participated in this study. And that's important because nationwide, most new infections of HIV are transmitted by someone who didn't know that they were positive, never had a chance to take any precautions to prevent transmitting to somebody else. So high rates of HIV, high rates of people not knowing that they're positive, 70%. The proportion who didn't use a condom last time they had sex of this group. Is that about the down low? Mm-mm. There's more. 50%. 50% is the proportion who didn't know their last partner's HIV status. Don't know, never asked, never came up, have no idea. In a setting with low condom use and high HIV rates. 45%. The proportion who said they were fairly sure, if not positive, that their partner was having sex outside the relationship. 45%. The folks who said, oh yeah, me too. And that's important because these concurrent relationships, when you're in one relationship and having sex with other people at the same time, believe it or not, they are a rapid transmission situation. You've sort of broken down all the firewalls for HIV transmission because when you are very, very first infected with HIV, your virus in your blood skyrockets, and you'll be more infectious to other people than you ever will be in the rest of your HIV/AIDS history. And so if you're getting newly infected with HIV and you're with someone else that you're having sex with too, there's a really high likelihood that you can transmit. Whereas if you got HIV, broke up, had another relationship, broke up, probably chances are that your virus would be down lower and less transmissible by the time you hit that next relationship, that next relationship, that next relationship. So what this shows is there's plenty of things going on in the heterosexual community that put us at risk for ongoing HIV transmission in DC. It also shows that people are taking, a lot of guesswork, a lot of chances about how they decide, what's safe. Rubik's Cube of you're safe, you're not, I think I like your hair, turn around 3 times and, I'm okay. So when we did all this, we tried to say, okay, how do we get concrete then? If you have to address just a couple of things in a relationship, what do you need to know to start to make a better decision about whether or not, you should use condoms or at risk for HIV? And we essentially say 3 questions. 1, in a partnership, do we know our HIV status? 2, is it just the 2 of us? 3, do we use condoms? So maybe Oprah will do a show on that, and then we can talk about more than just the men on the down low when we talk about heterosexual transmission of HIV. So next, men in prison, men in jail, men coming back from jail. Another, again, just pervasive, overwhelming part of the talk is that men coming out of incarceration have been really blamed for bringing HIV back to the community, just really venomously attacked and blamed. So what do we know about HIV and jail and prison? Well, we know it's actually a big deal. It's a really important question. And there's a lot of reasons why this is a real issue. Not the least of which is in this country, we haven't done a great job of addressing rape and sexual violence in incarcerated settings. And we've done an even worse job of addressing sex in incarceration. In the vast majority of prisons and jails in this country, condoms are actually prohibited. They're not just not available, they're prohibited. They won't allow people to bring them in, distribute them, anything. So we're not dealing with sex in prison. So it's obviously this is a real issue. But is it the only issue? What do we know about HIV in jail in DC? So our DC jails had a routine voluntary HIV testing program since 2006. And it is very popular. Everybody who comes in the door as part of their medical assessment gets offered an HIV test. And almost everybody accepts. So more than 90% of the folks who come through DC jail, men and women, get tested for HIV. Second thing about DC jail is we actually have condoms. Yay, we have condoms available. So we still might not be dealing with sex a lot, but we're at least providing some of the protections that deal with sex and sexuality. So reality is, here and now in 2010 in DC, you are more likely to accurately know that you're HIV positive and know your HIV status if you've been to jail than if you live in the community. Best place in the city to make sure you get offered an HIV test. So what happens? What do we miss? What's the risk of our missing the boat if we only talk about HIV and incarceration as the person coming out of jail as being either the villain who's bringing HIV back to the community? Well, we risk people in the community saying, well, hey, as long as I'm not having sex with someone who just came out of jail, I'm safe. I don't need to worry about it. Which, as we showed from the data, really aren't the case. What's the risk if we then only address
community, we know that most men, within the first week, if not their first month of getting out of incarceration, have unprotected sex. And we tell them it's okay because you didn't get HIV in jail, you're safe. But what's the reality in DC? These HIV negative men are coming back into a community with extremely high HIV rates, right? 5% HIV rates. But without the education information that says, hey, you have to pay attention to staying HIV negative when you go back to the community, because you're not just the vector. So, men coming back from prison, not the only thing we have to deal with in terms of HIV incarceration. Poverty. So what do we know about HIV and poverty? Well, certainly this is a real issue. Unfortunately, some of what we know about HIV and poverty sort of harkens back to South Africa. Really over the last decade, their previous president, Thabo Mbeki, made, huge headlines because he said, HIV doesn't cause AIDS, poverty causes AIDS. And he actually said HIV, the virus, doesn't cause AIDS at all. And because of that, and all of sort of government policy being based on his dialogue on that, hundreds of thousands of people have gotten infected and hundreds of thousands of people have died by being prevented of having some of the treatments that are life-saving if you believe a virus actually causes HIV. Now, when we're here in DC talking about poverty and HIV, that's really not what people are saying. People really know that HIV, the virus, causes AIDS. It's a much more complex dialogue than that. When we talk about poverty and HIV, and this is true, we think about vulnerabilities. On a social level, we say social determinants. If you are living in a poor neighborhood where people have traditionally had little health education, little access to services, little access to treatment, we see health disparities on a whole host of diseases, including HIV, and that's real. That's also why we target a lot of publicly supported programs to these kind of settings, okay? Second thing that people talk about when we talk about poverty and HIV is that individual level experience. So let's say if I'm a woman who has little job options, very little education, I'm dependent on my man who maybe is beating me, to feed my children, be housed, sort of stay okay. How can I negotiate condom use with that? How can I force him to use a condom? Or how can I prioritize HIV when, I'm prioritizing feeding my kids and paying the rent? So those are all very, I think, real issues. But if you take it too far, if that's the only conversation we want to have about HIV, you could actually say, well, if poverty, is really what's driving HIV, then wealth must be an HIV vaccine, right? So what do we know about rich people in DC? Okay? So we know a little bit. We did a study of 500 men, 500 gay men, and these men happened to be very educated. 80% had some college, going into a lot of college and a lot of graduate degrees. 70% made at least $40,000 a year, and 40% made at least $75,000 a year. So not an impoverished group of people. So if poverty is really what's driving HIV in DC, this group of folks should have extremely low HIV rates, right? No. So of these 500 men, 14% were HIV positive. 21% of the men over 30 were HIV positive. And so this is just a really important thing to keep aware of, because we risk, if we only talk about HIV and poverty, we risk making the assumption that people who are educated and are wealthy have no role to play in HIV prevention. But we also risk, in this very small 64 square mile town of 600,000 people that we live in, we risk thinking that there are stronger divisions than there are across income, just by income. In fact, particularly in African American communities and socially mobile communities, if you change your status, if you go to college, get your job, you don't divorce your community, right? You don't divorce your connections, your roots, your family, your friends. And so the social and sexual connections are not as divided as we think. So what does that mean? I'm going to wrap it up. Now what? now you know. Now I'm going to ask everybody here to just take one action. One action, it's not the only actions we all need to take for HIV, but it's one action, and it's one action and we all benefit. One action that sets off a chain of events that are going to help us change the face of HIV in the district. One action. When you go to your doctor, ask for the test. When you go to your doctor, ask for an HIV test. Now, we think because of how common HIV is and because of how many people are affected here in the district, that everybody should be offered an HIV test when you go to the doctor. You know, you go on the scale, you get weighed for obesity, you get your blood pressure checked for hypertension, you get offered an HIV test. But if you want to refuse, you can. That's okay. So why am I telling you to ask for the test? Oh, so you get a test. But more than that, so you change your doctor's level of understanding about who needs a test in HIV in DC. Because I can guarantee you, a lot of your doctors are going to look at you and they're going to say, why? Do you need one? They're not going to know a lot of the things you just heard here today. A lot of our medical providers are absolutely wed to this idea as well, because we've taught them this, that they can look at someone or talk to someone and know who doesn't need an HIV test. So one action, ask for the test, you educate your provider. And if you ask for the test, you ask for the test, and you ask for the test, eventually that provider, we think they're not going to wait to be asked anymore. They're just going to start offering it to that next person who walks through the door who doesn't know to ask for it. And then the third thing that happens is, I think, after you've asked for the test, you've had that interaction with the doctor, you've heard about what we know about HIV here today in DC, hopefully you'll be more willing to have a conversation, start talking about HIV. I don't care if it's at the water cooler, your dinner table, the bar. And by talking and breaking the silence, we can reduce the stigma, and we can all come together and help change the future for HIV in DC. So one action, ask for the test, and help DC take on HIV. Thank you.